Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello, welcome back. This is Adam Rosen. You're listening to the Total Knee Tips and Pearls podcast. I started a new season here, and the hope and the goal of this series of the next few podcasts is going to be actually geared more towards the primary care doctor, the internal medicine doctor, the ER doctor, the hospitalist, the medical student, the maybe intern starting out in orthopedics. For most of you that are PGY 2, 3, 4, 5 fellows, you may find some of this information basic. But what I hope that you do with the information then is hopefully pass this on to your colleagues that actually you think and you feel may benefit from this information. I think we all know it's pretty clear. There's a lot of information and data out there on the inefficient education of the musculoskeletal system in medical school. It was a study that I looked at back in JBJS in 2015. This was done in the UK, and it showed that only 21% of graduating medical students passed the MSK exam. There was an Indian Journal of Orthopedics actually in 2009 that showed only 5% passed. And when you look, approximately a third of ER visits are for orthopedic reasons, and a large number of primary care visits are for musculoskeletal complaints. So we definitely have to do a better job starting in the medical school arena. But for many of us that are already out in practice, this is a way that I'm going to try to do my best to offer some insight into some common complaints, common issues, common diagnoses, but most importantly also how to work them up and treat them. We see a huge number, for example, of the knee, and I'm going to go into this in more detail, of unnecessary MRIs. And that's a huge cost. So we're talking about the financial cost of medicine. This is an unnecessary test. But I'll go into even more detail of why many of the patients that I see had an out-of-pocket copay that was expensive, but also have a lot of anxiety and a lot of fear just because of what the report says. And it takes the time until they get to an orthopedic surgeon for us to actually respond to the medical jargon of the radiologist and put it into a layman's term for the patients and put their minds at ease. Jump right in, and there's a primer that I actually developed, and I'm going to give you a lot of information from that. And I've done a bunch of lectures over the years at a lot of primary care meetings to kind of cover these topics. So we're going to talk today specifically about non-traumatic knee pain and arthritis, typically your patient that's 50 years and older. So these are patients that you would expect actually non-traumatically would present to the primary. Not uncommonly, they'll actually make an initial appointment to see an orthopedic surgeon. But what's even worse is a lot of these unnecessary visits are seen in the emergency room setting. So arthritis, is one of the most common causes of disability in the United States. And when you look at 2005 data, 27 million adults in America had osteoarthritis. So it's a really, really big component of pain. And this has resulted back in 2010, a study looked at 78 million ambulatory care visits for osteoarthritis alone. So this is a very common complaint. We're not talking about a zebra here. Now, when patients come in, just like anything, you want to take a good history. But the history can be very vague and very confusing and very different from patient to patient. So I try to make a habit of asking my patients not what is their pain like, but I try to ask the patients what symptoms they have. And they may describe stiffness or achiness, sharp or stabbing pain, instability, swelling, catching, locking, burning. And, unfortunately, a lot of people have been taught this, locking and associated with a meniscus tear, but it's not true locking if the patient just feels like the knee kind of wants to get stuck. A lot of times we'll see that with arthritis, and it may be for multiple reasons, but it may be very different from the true locking from a large, unstable meniscus tear. And the other important thing to understand is although most patients with arthritis may have the typical slow kind of progression of pain, achiness, stiffness over many, many years, there's a lot of patients that will present with acute pain with no trauma, and the diagnosis turns out to be arthritis. And this is someone that steps off a curb and has pain. They turn and twist, or they bend down, or they just roll over in bed and the sheets catch their knee, and they'll have this acute onset of pain. When you get through with the exam, x-rays, turns out all they did was have arthritis. And it's hard sometimes to explain to these people, but letting them know that, it's not uncommon to have asymptomatic arthritis, and then there's some trigger that then causes these symptoms to start. Now, the other symptom and complaint, and some patients actually come in with their own diagnosis, is the idea of a Baker cyst. So this is a common referral to orthopedic surgeons that typically is not necessary. Now, the cause of the Baker cyst may be a necessary reason, but Baker cysts alone aren't necessarily an emergency. They're not a surgical problem, and there's not much that we can do for it specifically other than treating the disease. So just understand that Sir Morton Baker, he first described this back in 1877, 18, not 19. And this was a case series back then of 8 patients. And what he did in the initial patients, he actually lanced them. They reoccurred, and that's a common thing. It's the reason why the majority of doctors out there will not aspirate Baker cysts, because they come back. Most patients in his study actually improved with just wrapping and compression. Now, obviously, their sterility and antibiotics were different back then, but 3 of the patients where he actually IND'd or opened and lanced those cysts developed infection, 2 of which actually had amputations. So he was actually pretty ahead of his time, because he made the diagnosis and the treatment back then. And unfortunately, it's not always held to. So he noted that the fluid can go out the back of the knee and form the cyst, and it can go from the mid-calf to the upper leg. Even though the cyst may be large, you may not see an actual effusion or swelling of the knee joint proper in the front or the anterior aspect, and typically they'll get smaller over time. And he recommended back then, this was in 1877, he recommended the cyst should not be punctured or operated on. And the most common cause of the Baker cyst was from osteoarthritis. So he recommended that you treat it with anti-inflammatories, braces, wraps, rest, and ice. And he said it's really, really rare to need to aspirate these. So, when you hear about people aspirating them, you really have to ask the question as to why. Now, occasionally you may have a significantly large one that is extremely painful, and that may be the rare instance, but definitely not a reason to operate on these. It is prone to a problem and a disaster. Most likely will reoccur, but worse, could lead to an infection. So now, obviously, there's a lot more you'll take in the history and figure out all those things, but those are the basic, most important things of listening to the patients. Now, you also want to know, what treatments that they've used and failed, because, I have a lot of patients that will walk in and say, well, I tried anti-inflammatories, they don't work for me. I tried Tylenol, it doesn't work for me. And I'll ask specifically, how much did you use? Oh, I took it once. So the analogy that I throw back at them is, if you saw your primary and had pneumonia or strep throat, and they gave you a 7-day course of an antibiotic, and you took one, would you call the doctor's office and tell them that antibiotics don't work for you? And most of them kind of look at you and say, no, I wouldn't. So although those medicines may be great for a headache or a little ankle pain after, playing tennis, when you have acute pain, swelling, and this symptomatic knee, you may need a more extended, a more scheduled course. So I try to get my patients in the habit of taking an anti-inflammatory like ibuprofen or naproxen or acetaminophen if they need to use something other than an NSAID for a minimum of 3 days on a scheduled basis, no more than 7. And the majority of time, those symptoms may resolve. But it's important to kind of understand what they've tried. Have they used a brace? And one of the worst things that we see in orthopedics is, someone shows up at the ER. One, we'll get into x-rays. They get a non-weight-bearing x-ray. They have arthritis. There's no fracture. There's no ligament disruption. There's no tendon rupture. And they get placed into a knee immobilizer. And they get given crutches and they get given Vicodin. So then they show up in the orthopedics office going, I'm in this brace. The brace made my knee pain worse. I can't walk with the crutches. And I took the Vicodin and I got constipated, nauseous, and threw up. So arthritis treatment is not a knee immobilizer. Arthritis treatment is not non-weight-bearing x-rays. Arthritis treatment is not a narcotic. But when you're talking to these patients and you take this history, you then have to examine them. Now, discussing the examination is a little bit difficult in a podcast setting, but it is important to have a good, thorough examination of the knee. I see so many primaries when I do these meetings, they feel anything on the inside of the knee or medial side of the knee that's painful is a medial meniscus tear. But they may be pushing on the MCL. They may be pushing on the bone. They may be pushing on the pes anserine bursa. So you really have to understand the knee when you examine it. And you go, I can't do it. Oh, you can. You got through medical school and you took a cardiology, series of courses and lectures and rotations. And you understand that when you listen to the heart and you place your stethoscope in different portions of the chest, you're listening to different chambers and different valves. You've learned that that is important. And when we talk about a knee exam, the same things are important. So the simplest thing is just get the patient to walk. Watch them walk. Is the knee straight? Is it valgus or varus? We talk about valgus, the force is from the outside or lateral side. Varus, the force is from the inside or medial side. Do they limp? Does the knee straighten all the way? Does it buckle or give way? You can learn a lot just watching them walk. The next thing I have them do is when they're sitting on the examination room table is straighten and bend their knee. Watch how they move the knee. Do they protect it? Can they move it normally? Does it not straighten all the way? And then you can check the strength of the hamstrings, check the strength of the whole leg, but we're looking at the strength in the hamstrings and the quad specifically to look at the knee. Now you want to check ligaments. So checking the ligaments, the medial and lateral collaterals, you can check with the knee in regular extension, full extension, 0 degrees of extension, where the leg's straight. Let the knee bend slightly, check it again. You'll see subtle differences. You can check the ACL, the PCL. See is there instability from front to back. That may clue you in on some problems. Very commonly, I see pain that is missed and it actually was an MCL tear. That's the patient that should have had a brace. They come in to see me, they've continued to have pain for a week or so, and you examine them and they gap. It's abnormal. So if you're unsure, always check the other side. If the other side's there normal, you start to get in the habit of this is normal, this is not normal, and you may suspect an MCL tear. Now, when you palpate the knee, you should be thinking, am I palpating the medial femoral condyle, the lateral femoral condyle, the patella, the tibia, medially or laterally? Now you're on the joint line. And where do they actually have pain? Really have an idea in your head when you're pushing on things is where does it hurt, not just medial and not just lateral. And that helps you make a lot of differential diagnoses and rule things in and rule things out. Now, the extensor mechanism, if they tear the quad or patellar tendon, they're not going to be able to straighten the knee. You're going to feel a defect. The kneecap's going to look abnormally high or low, but you can also find tendinitis by pushing at the tendon where it inserts on the tibial tubercle, the inferior pole, the patella, the superior pole, the patella, mid-substance in the quad. So get an idea and have a very strategic algorithmic exam that you do for every single patient. And between listening to them and examining them, you should have a pretty good diagnosis. But now the next step is imaging. Now, for almost all orthopedic visits, we're going to get an x-ray. If somebody comes in with a history of chest pain, history of palpitations, and they see the cardiologist, you're going to get an EKG. You need the information. It's helpful. So the mistake a lot of people make, and I'm not casting blame because it may depend on the institution. It may be due to radiology. It may be your EMR. It may be how you order it. But it is extremely common for a non-traumatic knee injury that people will order x-rays and they get this useless for an orthopedic surgeon 3 view, which is an AP, an oblique, and a lateral. And they're non-weight bearing. So for us, we need different imaging. And many orthopedic surgeons and orthopedic departments have fought with institutions and the EMR and the internists and the hospitalists and the ER doctors and the radiologists. And it shouldn't be this hard. But the appropriate x-rays, are a standing AP. A Rosenberg, which is a flex knee PA view, is extremely helpful in patients over 50. A lateral view and some type of patella view, either a merchant or a sunrise. Why? We will see people get essentially at our institution, about $90. So it's about a $90 x-ray for the 3 view. It's non-weight bearing. They come in and see us. Now we have to do another x-ray. So now it's another $90. And the patient has been irradiated twice. And what's worse is they were told on the first x-ray a week ago that there's minimal arthritis. Joint space is well preserved. No arthritis noted. And then they come in a week later. Severe arthritis, varus deformity, bone-on-bone arthritis. Why? Because they were standing. And before they were laying down on the table. What's worse is you'll see, X-ray supine non-weight bearing, minimal arthritis. If suspicious for injury, get MRI, which is the radiology report. So the knee-jerk reaction is, I'll order the MRI. Now they get an MRI that costs about $1,200 around our institution, around our area. And now they come in with an X-ray, non-weight bearing, an MRI, and we say you need another X-ray, and patients get all bent out of shape. Well, why? I already had an MRI, because they've learned to believe that the MRI is the best test for them. And it may be great to rule out a rotator cuff tear, or in an athletic knee injury to rule out an ACL if you're not sure on the exam. But for arthritis, it's not necessary. It's a huge cost. And then they pay a copay, and they lay in a scanner for an hour. And if they're older and have arthritis, they probably have a bad back, and they may get claustrophobic. And now you've given them a sedative. So you have all this information, and it doesn't help us make the diagnosis because we need the standing view. Now, what's worse is the lack of the patellar emergent view, because it misses diagnoses. So I've actually seen people sometimes almost make the right diagnosis, or they made the right diagnosis, patellar dislocation or patellar subluxation, but they didn't get the appropriate image. And we can't tell, did they fracture off a piece of the femur when that kneecap went lateral? Or do they have what we call a dysplastic trochlea, which is making them prone to dislocate? Or what's worse is they fell on the knee, and on the lateral view and the AP view, it's hard to see. But if you got a Merchant or Sunrise, they actually had a fracture. And then those, ironically, are the patients that leave the emergency room or the primary care doctor's office without an immobilizer. So they have a fracture that was non-displaced that now is at risk of displacing. So, and I'll put these in the show notes. A weight-bearing AP X-ray. A Rosenberg is extremely helpful in patients over 50. A lateral of the affected knee, and a Merchant or Sunrise. And that should be your X-ray order. And if your institution doesn't do it, I would please ask you, take the time to put it in your favorites and save it. So it's a one click, and you don't even have to think about it after you put this in there, because you will get the appropriate image. It will help you make the appropriate diagnosis. You will save additional cost and radiation exposure to your patient. And your local orthopedic will be really happy because you're doing the right x-rays. They don't have to repeat them. Now, it's different in trauma. So you fall off a ladder, we're concerned a fracture. That's where a non-weight bearing x-ray may be appropriate as a first-line test, because you want to make sure that they didn't have a fracture. But we're talking mainly here about non-traumatic pain. Now, the MRI, and I've talked about it a little bit, but the MRI is not necessary for an arthritic knee as a first-line diagnosis. Now, there are times where I may order one. Why? So I have someone that has pain out of proportion. The x-rays are essentially normal. The patient's older, and I worry about an insufficiency fracture. That may help me. Or I suspect maybe somebody has a meniscus tear. They have very acute pain. X-rays don't look terrible as far as arthritis, but I'm worried about what's called SONC, or spontaneous osteonecrosis of the knee. MRI helps diagnose that. So those are really important things that we use to determine the diagnosis and the treatment. But in most instances, the MRI is not necessary. If you look at the majority of people over the age of 50, the majority of people do have meniscus tears and rotator cuff tears. So, usually Vegas wouldn't take those odds. If the majority of people are going to be positive, they're not going to let you gamble on whether or not I'm going to do this test and do you have a meniscus tear? I'll tell people, if they ask, could I have a meniscus tear? Yeah, most likely you do. If you have gray hair and wrinkles, you probably have a meniscus tear and a rotator cuff tear. But it may not be the cause or the source of the pain. There's actually a study in Journal of Bone and Joint Surgery, 2003. 91% of arthritic knees had meniscus tears. And 76% of age-matched asymptomatic patients without pain, had meniscus tears. So these are common. So if you treat the arthritis first and treat the symptoms first, and then if they do not get better, or if they have a locked knee, then we consider the meniscus as an etiology, because what tends to happen is that you order the MRI, they have a meniscus tear, a patient festers over the meniscus tear, they'll see an orthopedic surgeon, someone's going to operate on them, and then what we know is the majority of arthritic knees with meniscus tears do not get better with arthroscopy and get worse. So although it may be an option of last resort in patients that aren't bad enough for a knee replacement, it shouldn't be the first-line treatment. You shouldn't have pain, MRI, meniscus tear in an arthritic knee. So we want to work on the weight-bearing x-rays. Avoid the MRI. Now you're going to say, well, my patients, they're really demanding and they really want the MRI, and I really get put in a corner. I understand that. I get that. However, if you think back when every kid used to get antibiotics for ear pain, and then mom requested antibiotics, and we started to realize that wasn't necessarily the thing that was causing the ear pain. It was viral. It didn't need an antibiotic. And people were taught that the antibiotic was bad because we were inducing antibiotic resistance and we were giving kids antibiotics unnecessarily. So people have been taught to explain this to mom and to educate patients. And then patients are okay with that. And the same holds true for the MRI. I understand that your patient is going to be demanding and they're really going to want the MRI. But if we continue to allow the patients to decide their treatment, we're not doing them a good service, and we're not helping the entire medical system, especially when we look at the abundance of costs. So you need to take the time to explain this to patients. For me, I actually have little handouts. So I'll explain it to briefly and go, hey, go home and read this. And this is all the data on the percentages of meniscus tears common in patients, the overuse of MRIs, how it doesn't change treatment managements, and the patients get that and they understand that. Because what's worse is when I see patients come in with the MRI, two main things that stick in my mind over the years of having issues is the primary may not have a very good understanding of everything that the radiologist says, or they may probably don't look at the actual images the way that we do. And although the impression may be long-winded, the thing that they pick up on is the meniscus tear. So they let the patient know, or they have their staff call the patient, oh, you have a meniscus tear. And what's worse is they'll say, oh, you need an arthroscopy. You need a scope. You need to see a surgeon. So now patients come in with this impression from the radiologist because they all have access to their medical records now. And they were told they need an arthroscopy. And then as the surgeon, you're telling them if they have severe arthritis, they need a knee replacement. And then they start crying. Or that, yeah, they have a meniscus tear, but we're going to try A, B, and C first. And they get upset. And then they start to question their doctor and the orthopedic surgeon. And, it really creates this huge amount of animosity and angst and anxiety in the patients. I see a lot of patients that for a week or two were just so anxious because they got the report and it said full thickness, chondral loss, bone marrow edema, insufficiency fracture, chronic tear of the ACL, horizontal cleavage, maceration, extrusion of the meniscus. So all these things that they can't process. And I'll look at them because you can tell sometimes when these patients are really anxious. And I'll look at them and go, listen, I'm going to summarize this for you in one word: arthritis. And it just puts the patient at ease. And I just explained to them, I don't go back through chondrals, cartilage, bone marrow edema. This is a bruise. This is, I'll point things out on the pictures and I'll show all of this stuff. And I was like, but if we go back and now look at the standing weight-bearing x-ray that we did when you came in today, see how the bone's rubbing on the bone here? There's no space. All those things on the MRI, they're all expected. I knew they would be there based on this x-ray. And then you get, well, why did they order it? Well, why didn't they get the standing x-ray? And, we always have to kind of cover our other doctor friends, decisions. And you try to walk a tight line of, saying, oh, this is what they were thinking and probably did this and it's okay. And this is what we're going to do going from here. But again, weight-bearing x-rays, and do not order the MRI unless you have good reason. So we've done a whole bunch of the workup stuff. So now let's talk about treatment. Okay. So when we talk about treatment, I applaud all of my internist and family practice friends that make note and mention and talk about it. And I really have a hard time when people have BMIs of 40 and nowhere in there is it mentioned that they're overweight and they should lose weight and they were counseled on weight loss. Then I wind up being the first person. So I know a lot of people do, and I congratulate you. But it's a touchy subject for a lot of people, but you have to do it. It's our job. We're trying to make them better. I always tell people, we in the doctor world, unfortunately, have been very good at treating disease. Why? You're going to operate on someone. You're going to get them a CPAP machine for their sleep apnea. You're going to put them on, metformin for their diabetes. You're going to put them on Lipitor for their high cholesterol. You're going to put them on a whole bunch of medicines for their hypertension. And unfortunately, you kind of forget the fact that the cause of many of those diseases was due to the patient's chronic obesity. And I sit down and talk to the patients about how that weight that they're now carrying has increased the risk of arthritis in their knee and has probably led or played a major factor in their sleep apnea and their diabetes and their hypertension and their hypercholesterolemia And I'm never surprised. And luckily I educate my patients and they're not surprised when they do lose weight and they come back and they go, hey, I don't need my sleep apnea machine anymore. I'm only on one medicine for my blood pressure now and I'm off metformin and my sugars are better and I feel better. My back feels better. My hip feels better. My knee feels better. Why? Because we talked to them about weight loss. And you really need to take the time or have handouts or refer to a nutritionist or a metabolic clinic and get people to change the way that they eat. Change the way that they live, change the way that they exercise. So weight loss is number one. Anybody with a BMI over 25 with arthritis and knee pain, you should be talking and mentioning the weight as a potential cause and something that they can modify. The second thing is you really need to talk to patients about exercise. That so many patients are afraid to exercise. They're always afraid they're going to make their knee arthritis worse. And I let them know that's not the case. The analogy that I use is if you have brakes on your car and you're driving home, are you not going to step on your brakes because you're afraid you're going to wear your brake pads out? And they kind of look at you funny. I'm like, that's like your cartilage. We're asking you to use it because it's designed to be used. Now, if you slam on your brakes at every red light, you're wearing out your brakes prematurely. That's not advised. So if you have arthritis, we're not recommending running and CrossFit, but walking, stationary bike, swimming, low impact exercise is important because not only does it move the joint, but it increases strength and flexibility, and that has been shown to decrease pain. Now, our academy even recommends against, like I talked about before, against arthroscopy for patients with a diagnosis of osteoarthritis. So even though they may have a meniscus tear on the MRI that you ordered, if they have arthritis, arthroscopy is not the best treatment for them. Now, we talked about medicines early on, and that's something that I stress with a lot of my patients as a short-term fix. So if they're coming to see me and they're in pain and the diagnosis that we've made now is arthritis, I say, okay, let's first treat your pain. And we're going to start with something over-the-counter like ibuprofen or naproxen, or if there's a contraindication to an anti-inflammatory acetaminophen, or severe pain, the combination of the two. And we know now that the combinations of an anti-inflammatory with acetaminophen are equivalent to things like Tylenol with codeine and Vicodin. You should not, in this day and age, be prescribing a narcotic for arthritic knee pain. That is one of the reasons we are in this opioid crisis. So talk to patients first about acetaminophen and anti-inflammatories. Discuss the risks. Discuss the doses. I have a lot of handouts that I give, and each person's a little different. I always say, hey, ibuprofen, rule of threes, 3 pills 3 times a day for 3 days. Take it with food. Tylenol. Sometimes I'll do 2 pills twice a day for 2 days. I'll have patients that will take 1 and 1 or 2 and 2. So they'll do 1 ibuprofen and one Tylenol, or 1 ibuprofen, 1 acetaminophen, or 2 ibuprofen, 2 acetaminophen, depending on the severity of the disease, age, medical comorbidities. And this way they can increase.
We'll be back after a quick break.
Once a person is triggered, there are biological changes that happen in the brain that zap your energy, motivation, and sense of pleasure. Now, that in itself is not depression until people get into the depressive loop. It's very easy for people to stop doing things.
Yeah.
And you get into what we call an avoidance pattern of behavior. You stop doing things that give you a sense of mastery and a sense of pleasure, right? And you withdraw because the brain's basically like, hey, if you're not going to do this stuff, then I'm not going to give you the chemistry you need to want to do it.
Yeah.
So the less you do, the less you feel like doing. The less you feel like doing, the less you do. Now you're in the loop.
The control of their pain without using a narcotic. And that's the thing that really helps them. We got to get the pain under control. So we get the pain under control, then we can do those next 2 important things, is exercise. Exercise to strengthen the muscles and exercise to lose weight. That's going to be the key. That's going to be the important thing. It's not a long-term solution using anti-inflammatories forever and ever and ever, but this way it decreases the pain now, and then they can start an exercise program, and then they can start weight loss. Now, the simplest exercise that I review with my patients is something called the straight leg raise. Now, I'm in the office Monday, Wednesday, and Friday. I operate Tuesday, Thursday. So I have a form that has patients do this exercise Monday, Wednesday, Friday. And what it is I'll lay them down. I say, okay, we're going to put you on the table, lay back. Okay. Bend your left knee, put your foot on the table, lock your right leg, toes and ankles up, straighten your knee, lift it up about 10, 12 inches, bring it back down. Don't let your heel touch. Bring it back up and down 5 times. Okay, switch. Opposite leg, up and down 5 times, even if one leg is arthritic and the other one's normal, so they can compare. And I say, okay, go home and do 5 more of these. And I want you to do 10 of these Monday, Wednesday, Friday. And next week, I want you to do 20. And the third week, 30. And the fourth week, 40 up to 60. And if you can't get to 60, you might stay at 30 for a while and then only go to 35. And if it's really easy to get to 60, start back at 10 and add a hiking boot or a 1 pound ankle weight and do it again. But a 12-week strengthening program of that one exercise can decrease pain in some studies by up to 40%. You do not need to send these patients to physical therapy. You can start with this. And then the second thing I have them do is once they've gotten the anti-inflammatories for 3 to 7 days, the exercises Monday, Wednesday, Friday for a week or two, then I have them start an exercise program Tuesday, Thursday, Saturday. And if they have a stationary bike, great. Pool, great. Walking, that's okay too. And I start with 5 minutes. Like walk out your door, set your timer for 2.5 minutes. I don't care where you go. When it beeps, turn around and come home. Everybody should be able to walk 5 minutes or 5 minutes on a bike if you have the timer. And then do that 3 days. Next week, 10 minutes. Next week, 15 minutes, and kind of build up. And what you'd be surprised is that in 6 or 8 weeks, a lot of people are walking 20, 30 minutes a day. They're doing 60 leg lifts. They've modified what they're eating. They've lost weight. They take the anti-inflammatories for a week, and the knee pain's better. Because when you send patients to physical therapy when they have pain, more often than not, what I get is I saw my primary, he ordered an MRI, sent me to physical therapy. Physical therapy made me worse. Why? Their knee hurt. And they just spent an hour doing knee exercises. So for patients that progress with the exercises I give them, a home supervised exercise program, and then want to do more, then there may be a role for 1 or 2 visits of therapy. I don't like to send patients to therapy over and over and over again. I'd rather them go once a week or sometimes just once to learn exercises and then do them at home on their own. And they tend to progress better. Now, I understand some of the patients will never do it, so that's where therapy may be helpful because otherwise they're not going to do it at all. But that's the thing that gets them going, and that's the thing that makes the patients responsible for their own care and for their own health. Now, what if you have someone that has arthritis, maybe not ready for knee replacement, not ready to see a surgeon, but you've done the exercises, you've done the weight loss, they've done the oral medications, they still have pain. That's where a corticosteroid injection may be helpful. So if you do them, that's great. It's a payable event. It's a procedure if you're an RVU-based provider. Patients do like it, and it's a great way to reduce pain and inflammation acutely. I tend to use it depending on the patient. Someone has pain, shows up in my office, they're getting ready to go on a trip, daughter's getting married, I might do it at the get-go. Otherwise, I really try to start with exercise and pills first and save the invasive procedures for once those things have failed. And everybody's different as far as timing. Most surgeons that I know, will try to space them out every 3 or 4 months. Everybody has different philosophy on how many would give in total. Depends on the patient. We do like to limit them prior to surgery. So there are some studies that show within a 90-day interval of surgery, an injection increases the risk of infection. So just keep that in mind that if you're seeing somebody, say, for a pre-op for knee pain, because they have a knee replacement scheduled in a month, don't give them a cortisone injection because they're hurting today because they're having surgery. And then that surgery may be canceled because it may increase the risk of infection. So it's really important to kind of understand that. And the other important thing, though, too, and I'm sure this probably isn't everywhere, but a lot of times the orthopedic physician assistants are excellent. A lot of times we'll see patients that don't really need an operation, but the primary sees them, they have pain, and they'll send them to the orthopedic surgeon. Don't let them schedule with the PA. PAs are great, and PAs can diagnose. They can order the appropriate images if the weight-bearing x-rays weren't done. They can review the exercises. They can give cortisone injections. And what's nice in a busy practice that if they see someone that they know is a surgical candidate, they just walk down to the doc and kind of fast tracks the patient in. But when patients get funneled into the orthopedic surgeon for every pain that is not always necessarily a surgical problem, and then on the backside, you're wondering why the wait times are so great at your orthopedic surgery center near you. It's because those surgeons are seeing a whole lot of patients that didn't need surgery. So we're happy to see everybody. That's the hard part for me. I love seeing patients because if they walk in the door without anything, I know I can do the right tests, the right treatment, give them the right diagnosis, and get them on the right path. So they didn't go through this sort of maze of providers and tests that maybe didn't help them or maybe weren't necessary. But at the same time, at the end of the day, I operate on people. So, I need to see people that need an operation so I can also use my services and my skills in the operating room to help them. But that's a very sort of fast, but somewhat extended version of my knee talk that I've given in forms and fashions at different primary care centers and different lectures over the years. So what I'm going to try to do is in the show notes, I'm going to try to link up some links. I'll link up the links that I have on my website of handouts that I use in my office. You're free to use them and modify them as you see fit. I also will put on there a link to our Orthopedic Academy that has a knee exercise handout. So this way you could give that to your patients in the office in lieu of sending them to physical therapy. I'll also list again the specific 4 x-rays that we like as far as weight-bearing x-rays. So this way you'll have those and you can copy and paste them, talk to your institution, and save them. And I really hope that this is the beginning of a sort of podcast orthopedic education, because I know, it's not taught well in medical school, and you are going to see patients that have orthopedic issues. So in the next few episodes, I'm going to try to go into hospital consultations, hip fractures, Achilles, tendinitis, tendinosis, ruptures, and I'll try to cover some different orthopedic topics that I think are common and would be helpful, in the hopes that this information helps you treat your patients, make more accurate diagnoses, and refer the appropriate patients at the appropriate time. So thanks for listening. If you have other friends, colleagues, residents that would enjoy this information, please forward this podcast and this information on to them. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast, a primer for the office-based provider. Stay safe. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.